I want you to imagine, just for a moment, that you are standing inside an emergency room.
Okay.
Specifically, you're in a severe burn unit, right? The doors swing open, and a patient is wheeled in with severe thermal burns.
A really horrific scenario, yeah.
Truly. And historically, the standard of care in that room, like the absolute best thing modern medicine has to offer is this procedure called tangential excision.
Right.
And to put it bluntly, I mean, that basically means a surgeon takes a surgical blade.
Yeah, typically a specialized medical knife.
Or a dermatome.
Exactly. And they physically they shave away the dead, burned tissue.
The Escher.
The Escher, right. And the surgeon has to keep cutting deeper and deeper into the patient until they reach healthy bleeding tissue.
It's incredibly traumatic.
It's deeply invasive. And frankly, it's a pretty medieval process. I mean, it's bloody. It requires a fully prepped operating room. And
you lose a lot of healthy skin, too.
You do.
Yeah.
Because, the human hand can only be so precise.
So now I want you to imagine an entirely different scenario. We take that surgical blade and we throw it in the trash.
Love it.
We replace it with a highly concentrated mixture of plant-based enzymes, specifically derived from the stems of pineapple plants.
Yeah, a non-surgical biologic gel.
Right. And the doctor just applies this gel directly to the wound right at the bedside.
No operating room scheduling required.
None at all. 4 hours later, they literally wipe it away, and that gel has effectively melted away the dead tissue.
While leaving the healthy, viable tissue completely untouched.
Exactly. No scalpel, barely a drop of blood. Welcome to Griffonomics. Today we're diving into MediWound, trading on the NASDAQ under the ticker MDWD.
It's a profound shift in the foundational philosophy of tissue repair.
It really is.
We're moving from mechanical force to targeted biochemistry.
Yeah.
We're letting molecular science do the heavy lifting that surgeons have had to do with brute force for decades.
And understanding that shift, that is our core mission for you, our listener, on this deep dive.
We have a massive stack of source material sitting in front of us today.
We really do. We've been combing through corporate presentations, deeply granular SEC financial audits.
The fun stuff.
Oh, yeah, the really fun stuff. Earnings call transcripts, and just a mountain of clinical trial data.
And we are doing this to figure out a glaring discrepancy on Wall Street, right?
Right. We want to understand how a biotech company that possesses over $140 million in sovereign defense backing,
plus a potential multi-billion-dollar chronic wound care asset.
Exactly. How is a company like that currently trading at an enterprise value of under $200 million?
When you lay out the fundamental architecture of the company, it presents a fascinating forensic puzzle. I mean, the market is currently pricing in a massive amount of skepticism.
Huge skepticism. So our goal today is to synthesize all of this clinical data and untangle the financial mechanics to explain why, the market might be fundamentally mispricing this asymmetric turnaround opportunity.
We really have to separate the short-term operational noise like the administrative delays and factory bottlenecks from the long-term clinical reality of what their drugs actually do to human tissue.
So let's start with the biology and the commercial reality of today.
Right, before we even look at their future pipeline or the chronic wound market.
Yeah, we need to focus on the product that is already FDA approved. That pineapple-derived enzyme I mentioned in the intro, it is a commercial drug called NexoBrid.
And to understand why it's causing such a stir, we have to look under the hood at its mechanism of action, because this isn't just like an aloe vera gel.
Oh, not at all.
This is a highly engineered biologic.
So let's dive into that. It all comes down to proteolytic enzymes, right?
Yes, NexoBrid uses a bromelain-enriched enzymatic mixture. And in biology, an enzyme is essentially a catalyst that speeds up a chemical reaction.
Think of it like a molecular lock and key mechanism.
That's a great way to put it. The enzymes in NexoBrid are perfectly shaped to bind with the specific proteins found in dead necrotic tissue.
Things like damaged collagen.
Exactly. Collagen, elastin, and fibrin that make up the burn eschar. They lock on to those dead proteins and cleave them apart, effectively dissolving them.
But the magic trick here, the thing that blew my mind, is that they only fit the locks on the dead tissue.
That is the crucial differentiator. Healthy, viable skin cells have natural defense mechanisms.
Protease inhibitors, right.
Right, protease inhibitors that actively neutralize these enzymes. So the gel actively eats the dead flesh, but is completely neutralized the second it touches healthy flesh.
The precision is a molecular.
It is. In head-to-head clinical trials against standard surgical excision, NexoBrid achieved a 93% complete Escher removal rate.
93%? That's wild.
And again, it accomplishes this in just 4 hours, right there at the patient's bedside.
The metric that really stood out in the clinical data wasn't just the removal rate, though. It was the blood loss.
Oh, the blood loss data is staggering.
It is. When a surgeon uses a scalpel for tangential excision, the average blood loss is 815 milliliters.
That's nearly a liter of blood.
Almost a liter. But with NexoBrid, that average drops down to just 14 milliliters.
14 milliliters is practically a rounding error in a trauma bay.
It really is.
When you preserve that much blood and you preserve the viable dermis underneath the burn that a scalpel would have otherwise scraped away, you drastically alter the trajectory of the patient's recovery.
Because the data shows that using NexoBrid reduces the need for subsequent surgical interventions by 94%.
Like severe skin grafting. 94% less.
I want to pause on that because it's just so vital. We aren't just talking about, a slight improvement in patient comfort.
No, not at all.
A 94% reduction in surgical intervention means you are keeping trauma patients out of the operating room entirely.
You are freeing up surgical beds.
And anesthesiologists, nursing staff, everything. The hospital economics of that are massive.
Which brings us to the commercial paradox of MediWound.
Right. The drug works. The FDA approved it. But looking at the balance sheet, it feels like they are running a highly successful bakery where they only own one tiny oven.
That is the perfect analogy. And that is the core bottleneck currently suppressing the company's valuation.
Let's unpack the exact numbers there.
So, MediWound's commercial distribution partner in the United States is Vericel. In the most recent financial quarter, Vericel reported record hospital orders for NexoBrid.
Across approximately 80 different U.S. burn centers, I believe?
Yes, 80 centers. The market demand is visibly surging as hospital protocols update to include enzymatic debridement. However, if you look at MediWound's finished goods inventory across all of its global territories, it is essentially sitting at zero.
Zero. They are literally selling every single vial the exact second it comes off the manufacturing line.
Which means their revenue is artificially capped.
Right. It is completely constrained by the physical limits of their factory, not by a lack of demand. Doctors want the drug.
They just can't make it fast enough.
So how do they smash through that ceiling?
The structural fix is a massive infrastructure upgrade. They've built an expanded cGMP manufacturing facility located at their corporate headquarters in Yavne, Israel.
Let's clarify what cGMP means for you, our listeners, who don't spend their days reading FDA regulatory manuals.
It stands for Current Good Manufacturing Practice.
Right.
In the pharmaceutical world, you can't just make a drug in a clean kitchen. A cGMP facility requires extreme, rigorously documented standards.
We're talking air filtration, water purity,
material traceability, sterile workflows, everything. Building one of these is a monumental multi-year capital expenditure.
And this new facility in Yavne isn't just a minor extension, is it?
No, it is designed to increase their commercial batch capacity by 600%.
A 6x capacity surge, that is huge.
But biotech investors have been spooked because the timeline for this new mega facility got pushed back earlier this year.
Yeah, and it resulted in a hit to the stock price. So I want to unpack the specific regulatory nuance of that delay, because when the market hears European Medicines Agency audit delay, everyone instantly panics.
They assume the drug is tainted or the factory is contaminated.
Exactly.
Which is a complete misinterpretation of the actual events. Management was incredibly transparent on the earnings call about the feedback from the European Medicines Agency, or EMA.
Right. Because the physical plant is fully built.
The heavy machinery is installed and commissioned. But during a pre-audit, the EMA requested operational modifications.
Meaning what exactly? Like moving clipboards, changing where people stand?
Quite literally, yes.
Yeah.
It was about clean room workflows and documentation procedures.
Really?
Yeah. How do personnel move from Zone A to Zone B to minimize particulate transfer? How are the batch records physically handled in the sterile environment? The EMA had zero issues regarding product quality, product comparability, sterility, or safety.
Okay, so it's not a safety thing.
Not at all. They simply wanted the operational choreography tweaked before they would stamp the final approval.
Okay, so they have to redesign the dance routine in the clean room. When does that actually get finished, and when does the money start flowing?
So, MediWound is completing these operational tweaks in the fourth quarter of 2026.
Q4 2026, got it.
This allows them to begin commercial validation manufacturing in early 2027. And the EMA is expected to formally approve commercial supply from the new plant in the second half of 2027.
And the strategic, so what? Here's how they route the supply, right?
Exactly.
Once that new facility goes online, the European commercial shipments will be fulfilled entirely by the new 6X plant.
Which instantly frees up the older legacy manufacturing lines to dedicate 100% of their volume to the U.S. market and government stockpiles.
Boom! The revenue ceiling shatters.
It transforms the company from a supply-constrained boutique into a high-volume commercial biologics supplier.
Now, you just mentioned government stockpiles, which is the perfect bridge to our next topic.
Right, the defense contracts.
Because NexoBrid's clinical advantages aren't just appealing to civilian burn units, they are actively reshaping modern military medicine.
It's a huge part of their story. Sovereign defense funding is a foundational pillar of MediWound's business model.
And it provides an incredibly rare safety net for a biotech company of this size. I mean, to date, they've secured over $140 million in cumulative, non-dilutive government funding.
Non-dilutive being the key word there.
Yeah, explain why that matters to investors.
Well, they aren't issuing millions of new shares and diluting retail investors to get this money. The government is just handing them cash to solve problems.
Which is amazing. And the crown jewel of this funding is the recent prime contract awarded by BARDA in April 2026.
Right. BARDA, the Biomedical Advanced Research and Development Authority. It's the U.S. government agency responsible for securing the nation against bioterrorism, chemical threats, mass casualty events.
They awarded a 10-year contract valued at up to $197 million to Vericel, MediWound's U.S. partner.
And the stated goal of that contract is to secure the U.S. strategic national stockpile for burn mass casualty incidents.
So if a catastrophic event happens, like a chemical plant explosion or a large-scale terror attack, the government needs a way to treat thousands of burn victims simultaneously.
Exactly, especially when there aren't nearly enough surgeons to go around.
But let's clarify the mechanics of how this money actually reaches MediWound.
So Vericel holds the prime contract with the U.S. government. But to actually execute the science and physically produce the drug, MediWound and Vericel signed a Master Services Agreement, an MSA.
Got it.
Under this MSA, MediWound performs the underlying research and development, as well as the manufacturing.
So MediWound is the engine and Vericel is the chassis.
Perfect way to frame it.
When does MediWound actually start recognizing the revenue from this MSA on their balance sheet?
The revenue recognition mechanics kick in during the second half of 2026.
Okay.
They begin recognizing development revenue as they initiate the first major R&D program under the MSA.
And that specific program is fascinating. They are expanding NexoBrid's official label to treat combat blast and friction trauma.
Yes.
Now, I genuinely struggled with this concept when I was reading the source material. Like, how exactly does a drug designed to melt away thermal burn tissue translate to a battlefield blast?
It's a completely different type of wound, right?
Exactly. When I think of an artillery shell or an IED explosion, I'm thinking of kinetic impact.
Right.
I'm thinking of concussive force, shrapnel, dirt, shredded tissue, not necessarily a clean thermal burn. Why would you use a pineapple enzyme on a blast wound?
It requires a real paradigm shift in how we view traumatic wounds.
Yeah.
And to answer that, we have to look at the real-world data generated by the Israel Defense Forces, the IDF.
Because they actually tested this in the field.
They did. They conducted a study analyzing nearly 5,000 combat injuries. And impartially speaking, the data revealed that 71% of battlefield blast and thermal injuries are treatable with NexoBrid.
71%. That is a staggering majority of combat casualties.
The mechanism is what makes it so effective. In a high-explosive blast, the kinetic wave forcefully drives microscopic and macroscopic foreign debris, shrapnel, gravel, uniform fibers, dirt deep into the skin and muscle.
And this debris is surrounded by shredded necrotic tissue.
Right. If you leave that debris in the wound, it becomes a breeding ground for severe limb-threatening infections.
So traditionally, a combat medic or a surgeon has to manually scrub or literally dig that debris out,
which causes further tissue damage and intense bleeding. But the IDF data showed that applying NexoBrid successfully clears 92.5% of those embedded foreign particles.
Wait, it clears the shrapnel?
Yes.
How? It's an enzyme. It dissolves protein, not metal or rock.
Right. It doesn't dissolve the metal. It dissolves the damaged necrotic tissue that is anchoring the debris in place.
Oh, I see.
Once the dead tissue melts away into a liquid, the shrapnel and dirt simply float loose. You essentially wash the blast debris away without having to dig for it.
That is incredible. In a combat zone where you might have dozens of casualties pouring into a triage tent and, limited surgical lighting.
Exactly.
Being able to slather a gel onto a wound and wipe away the debris 4 hours later isn't just a cost-saving measure. It is an absolute triage necessity.
It saves limbs.
And the U.S. military clearly agrees with that assessment because the Department of War stepped in.
They did. They layered an additional $18.3 million non-dilutive contract onto MediWound.
And the specific mandate of that contract is brilliant. They want MediWound to engineer an unrefrigerated, room-temperature stable formulation of NexoBrid.
Because the logistics of cold chain supply in a war zone are a nightmare. You cannot guarantee a functioning freezer in a contested off-grid operating environment.
Or a forward operating base in the middle of a desert. If the power grid goes down, your standard biologic drugs just spoil.
Precisely why this new formulation is the holy grail for combat medicine. The DoD wants the ability to toss a freeze-dried biologic powder into a combat medic's backpack.
So the medic can carry it in 100-degree heat, mix it with a sterile liquid in the field, and enzymatically debride a blast wound right there in the dirt.
Achieving that would completely revolutionize tactical combat casualty care.
And from a financial perspective, it pushes their total non-dilutive defense funding to over $140 million.
That massive influx of government cash provides an incredible financial moat for the company's broader research pipeline.
Right, which is huge. So let's shift gears and talk about that broader pipeline. Because as dominant as NexoBrid is becoming in acute burns and military trauma, the company's true blockbuster potential lies in an entirely different setting.
Really does.
Institutional analysts aren't obsessed with MDWD because of military contracts. They are obsessed because of the multi-billion-dollar outpatient chronic wound clinic.
Yes. We need to talk about their next-generation drug candidate, EscharEx.
This is where the valuation geometry of the company completely transforms.
NexoBrid targets an acute market-severe burns, which represents a U.S. total addressable market of roughly $300 million.
Okay, $300 million. But EscharEx is targeting chronic wounds.
And that is a total addressable market of $4 billion.
$4 billion. Let's unpack the biology of a chronic wound for a second. We're talking about venous leg ulcers, diabetic foot ulcers, and pressure ulcers.
These aren't like paper cuts or even burns.
No, these are wounds that become biologically stalled. They refuse to heal. They get trapped in this endless cycle of inflammation surrounded by necrotic tissue.
And the legacy standard of care in this space is a drug called SANTYL, manufactured by a massive medical company called Smith Nephew.
Okay, let's unpack this. I was reading the clinical history in our source documents, and I was genuinely bewildered. SANTYL was approved by the FDA in 1965.
It is a remarkable artifact of clinical inertia.
1965, the Beatles had just released the album Help, and doctors were prescribing this exact same wound ointment.
Right.
How has a drug gone entirely unchallenged for 6 decades in modern medicine?
Well, it survived because there simply hasn't been true biochemical innovation in this highly specific niche. Plus, chronic wounds are notoriously difficult to run clinical trials for.
Okay.
But to understand the sheer scale of the opportunity for EscharEx, we have to perform a strict clinical and economic audit of SANTYL.
Let's do it.
Despite being a 60-year-old drug, SANTYL generates over $400 million in annual U.S. revenue.
Over $400 million.
Yet, it has severe, debilitating clinical limitations. SANTYL is a single-target collagenase.
Break that down for us. What does a single-target collagenase do?
It only breaks down collagen. But if we look at the microscopic environment of a chronic wound bed, it is not just made of dead collagen.
Right. What else is in there?
It is a complex, hardened matrix of fibrin, elastin, damaged collagen, and a thick layer of heavy bacterial biofilm.
So SANTYL is like bringing a wrench to a job that requires a wrench, a screwdriver, and a blowtorch.
That is an excellent way to conceptualize it, yeah. Because it is only a single enzyme, it acts incredibly slowly.
How slowly are we talking?
The label requires the patient or nurse to apply it daily for anywhere from 4 to 8 weeks.
Up to 2 months of daily application.
And even after 2 months, it frequently fails to completely clean the wound, meaning the patient ultimately has to undergo supplemental sharp surgical debridement anyway.
It's an expensive, agonizingly slow ointment that often ends with the patient getting their leg scraped out with a scalpel anyway.
Exactly.
Now, let's contrast that with EscharEx. How does MediWound's candidate perform in a head-to-head clinical audit?
The contrast is night and day. EscharEx leverages the same foundational technology as NexoBrid, It is a multi-enzyme complex.
So it has the wrench, the screwdriver, and the blowtorch.
Exactly. It contains a symphony of different enzymes that simultaneously attack the fibrin, the elastin, and the collagen.
Okay, what does the data look like?
In their randomized phase 2 clinical studies, researchers evaluated a very specific endpoint: the incidence of complete wound debridement within just 2 weeks.
Just 2 weeks.
In the EscharEx cohort, 63% of patients achieved complete debridement.
A completely clean wound bed in 14 days. And how did the SANTYL cohort perform in that same 2-week window?
0%.
Right, really?
Literally 0% of the patients treated with SANTYL achieved complete debridement in 2 weeks.
0. Wow.
The statistical significance of that difference is profound. The p-value was 0.001.
For our listeners who haven't taken a statistics class recently, explain what a p-value of 0.001 actually means in the context of FDA data.
Sure, a p-value measures the probability that your clinical trial results were just a random fluke. A p-value of 0.001 means there is a 1 in 1,000 chance that EscharEx beat SANTYL by sheer luck.
How?
It provides mathematical certainty that the multi-enzyme complex is vastly superior, and this efficacy translates directly into treatment efficiency metrics.
Let's hear the metrics.
XantoX reduces the average time to a fully prepared wound bed from 76 days down to just 48.4 days.
That's a massive time save. And what about that bacterial biofilm you mentioned earlier?
Because EscharEx rapidly breaks down the underlying necrotic matrix, it demonstrated the ability to eradicate 100% of baseline bacterial biofilm.
100%.
Yes. And in diabetic foot ulcers and venous leg ulcers, eradicating biofilm is literally the difference between a wound healing and a wound becoming infected to the point of requiring an amputation.
Hearing those metrics, it makes total sense why an independent global consulting firm recently updated their market assessment for EscharEx.
It expands the horizon entirely.
Right. They expanded the total addressable market to $4 billion across venous leg ulcers, diabetic foot ulcers, and pressure ulcers. Consequently, they elevated EscharEx's projected U.S. peak sales potential to $1 billion.
Think about the pure economics of an outpatient wound care clinic. If you have a drug that clears a wound in 2 weeks versus 8 weeks, you completely alter their profit margins.
You increase the throughput of patients.
You drastically reduce the nursing time required for daily bandage changes, and you accelerate the patient's path to actual wound closure.
But, that billion-dollar peak sales number is a massive carrot. But to capture it, MediWound has to actually cross the finish line.
They must execute flawlessly in the clinic.
And this is where a lot of the stock's volatility came from this year. Let's map out exactly where the EscharEx trials stand today.
The primary focus is the Phase 3 value trial. This is their pivotal global trial evaluating EscharEx in venous leg ulcers, or VLUs.
Okay.
It is a massive undertaking, a 216-patient double-blind design operating across approximately 40 multinational sites spanning the U.S., Europe, and Israel.
And we have to address the elephant in the room regarding this trial. In May of 2026, management announced a timeline adjustment.
Right.
They pushed the trial milestones back by an entire quarter, shifting the expected completion to the end of Q1 2027. And Wall Street notoriously hates uncertainty, right? They severely punish timeline delays in clinical stage biotech.
They absolutely do.
So let's dig into the why. Why did it shift? Was the drug failing?
No, not at all. The delay was entirely administrative and operational. It was driven by two primary factors, both rooted in the sheer complexity of running a global chronic wound trial.
Okay, what was the first factor?
The first factor was the extreme stringency of the inclusion criteria.
Explain what you mean by inclusion criteria. Like, you can't just enroll anyone who walks into a clinic with a bad leg.
Absolutely not.
Yeah.
You are dealing with an elderly, highly comorbid patient population. Many of these patients have severe diabetes, arterial blockages, and heart disease.
Okay.
To ensure the trial data is pristine and defensible to the FDA, the study protocol requires a very specific Goldilocks wound.
A Goldilocks wound.
Right. It needs a specific baseline wound area and a specific percentage of non-viable tissue. Furthermore, the trial sites have to meticulously screen out patients with severe peripheral arterial disease or active systemic infections.
Because those conditions would prevent the wound from healing regardless of how well the debridement enzyme works.
Precisely. You essentially have to find the perfect ulcer to prove the drug's efficacy without background noise ruining the data. They had to screen over 1,000 patients just to find the 216 candidates that met these exact baseline parameters.
That sounds incredibly tedious. What was the second factor?
The second factor causing the delay was administrative lag in activating the clinical trial sites across Europe. You were dealing with dozens of different local institutional review boards, ethics committees, national regulatory authorizations.
Oh, wow. Getting 40 hospitals to agree on the same paperwork takes time.
Exactly.
Okay, so the delay wasn't clinical failure. It was the bureaucracy of perfectionism. What is the current status? Are they actually going to hit this new Q1 2027 target, or is this going to be a constantly moving goalpost?
During the Q2 2026 earnings call, CEO Overgonen drew a line in the sand. He stated firmly that over 90% of the clinical sites are now fully onboarded and actively recruiting. The site activation bottleneck has been completely resolved.
Okay, I'm going to push back here, kind of stepping into the shoes of the skeptical analysts who are grilling management on that exact call.
All right, enough.
If the bottleneck is resolved, why won't management just give us a rolling month-by-month patient count? Like, if you want to reassure the market that the trial is on track, just tell the investors exactly how many patients enrolled in June and how many enrolled in July. Why all the secrecy?
It's a highly logical critique, and it's exactly what analysts like Chase Knickerbocker from Craig-Hallum were asking.
Right.
But you have to view this from a clinical governance perspective. Management's hands are legally and ethically tied. Providing rolling per-site patient counts in a pivotal, double-blind trial risks unblinding the study.
Wait, how does giving a number unblind the study?
Because the medical community is small. If you announce exactly how many patients were enrolled in a specific week, site investigators can start triangulating data, trying to figure out which patient got the active drug and which got the placebo based on localized enrollment bursts.
Oh, I see.
And introducing any operational bias completely compromises the integrity of the data in the eyes of the FDA. If the FDA senses that the blind was broken, they will throw out the entire trial.
Wow. So giving daily updates to satisfy Wall Street traders could literally jeopardize a billion-dollar asset.
Exactly. Management's strict policy is to focus only on the locked, pre-specified catalysts.
Okay.
They reaffirmed that both the pre-specified interim sample size reassessment, which occurs when 65% of patients complete their 12-week evaluation, and the full enrollment of all 216 patients, will definitely occur by the end of Q1 2027.
And importantly, the CEO noted they don't need any speculative trend improvements to hit that date, right?
Right. The current mathematical pace of enrollment gets them there.
And once enrollment finishes in Q1, the clock starts ticking toward the massive binary event, the top-line data readout in mid-2027.
That is the moment of truth.
But they aren't just putting all their chips on venous-like ulcers, are they?
No. To capture that full $4 billion market, they need FDA labels beyond just VLUs. In the fourth quarter of 2026, they are initiating a 50-patient randomized phase 2 trial for diabetic foot ulcers, as well as a separate open-label study for pressure ulcers.
So they are systematically building the clinical foundation across all three major chronic wound categories simultaneously.
Yes.
All right, we've covered the operational delays with the European factory, and we've analyzed the one-quarter push in the phase 3 trial. Now we need to see how these factors are actually showing up on the balance sheet and what the company is promising Wall Street. Let's do some financial forensics.
We really have to look at the near-term financial guidance versus the current reality, because this discrepancy is exactly what triggered the post-earnings stock decline in August.
Here's where the math gets genuinely confusing for me. In the first half of 2026, MediWound generated just $4.57 million in total revenue.
Right.
Yet management came on the earnings call and stubbornly reaffirmed their full-year guidance of $24 to $26 million.
Which means, to hit the midpoint of that guidance, they have to recognize roughly $20 million in revenue in the second half of the year alone.
That is an approximately 335% sequential jump from the first half. That looks like a sheer cliff face. How on earth do they reconcile a $20 million second half when they couldn't even break $5 million in the first 6 months?
Right, especially since they can't suddenly sell more NexoBrid, because we already established their factory is maxed out and inventory is zero.
Exactly.
You have to understand how revenue recognition works in biotech partnerships, specifically under generally accepted accounting principles. This steep second-half bridge is heavily driven by administrative timing. not by physical product sales.
Break that down. Where is the money actually coming from if it isn't from selling vials?
It comes from recognizing development milestones. Remember the Vericel MSA and the BARDA contracts we discussed
Yeah,
earlier?
it's the military and stockpile stuff.
MediWound is initiating the blast and friction injury R&D under that Vericel MSA in the second half of the year. When they hit specific research milestones, large chunks of cash are unlocked and recognized as revenue.
Oh, I see.
Furthermore, they are receiving active milestone payments from the $18.3 million Department of War battlefield contract as they hit formulation targets for the room temperature version.
So the revenue is contractually locked in with the U.S. government. It's just a matter of the accounting calendar clicking over.
Precisely. They're also supplying commercial NexoBrid to Vericel, to Kanken in Japan, and to various European markets, while receiving legacy BARDA direct program funds.
Okay.
The $20 million bridge is primarily service and milestone revenue that mathematically activates in the second half of the year.
Okay, so the top line revenue makes sense. But what about their profitability? I was digging through the Q2 filings, and their gross margins squeezed down to an incredibly painful 10.9%. How do you survive as a business with a 10% gross margin?
That margin compression is an illusion of timing. It is a direct result of the facility transition.
The Yavne plant.
Right. They absorbed massive one-time scale-up costs and fixed overhead associated with getting the new 6X Yavne plant ready for its EMA audit.
Got it.
Think about it. They have a massive state-of-the-art manufacturing plant, fully staffed, climate-controlled, and running test batches. But it isn't legally allowed to sell commercial product yet. When a plant isn't running at full commercial scale, those fixed costs completely crush your gross margin percentage.
It's the equivalent of paying rent and staff for a massive restaurant before opening day.
Exactly.
But once the doors open, what happens? Let's look at the multi-year trajectory. What happens when the 6X facility turns on in 2027 and EscharEx potentially hits the market in 2028?
The financial models provided by management are aggressive but structurally sound once that bottleneck is removed.
Yeah.
They project top-line revenue hitting $32 to $35 million in 2027.
Okay.
And that growth is driven purely by uncapping the NexoBrid supply bottleneck and supplying Europe. And then the projections jump to $50 to $55 million in 2028, assuming the initial commercial contributions from the launch of EscharEx.
That would mean tripling their revenue from the 2025 baseline of $17 million.
Yes.
Tripling revenue in 3 years sounds fantastic on a slide deck. But do they have the actual cash on hand to survive until 2028 without diluting shareholders into oblivion?
Their balance sheet armor is actually quite robust for a company of this size. They reported $36 million in cash and absolutely zero long-term financial debt.
Zero debt is great.
Additionally, they have a $29 million warrant backstop expiring in November 2026.
Explain the warrant backstop. What does that mean?
Essentially, existing investors hold financial instruments called warrants that allow them to buy more stock at a predetermined price. If the stock performs well as these clinical catalysts hit, those investors will exercise the warrants, injecting an additional $29 million of cash directly into MediWound's treasury.
Okay, but even with that cash, how do they prevent their operating expenses from exploding as revenue triples? Usually when a biotech company gets a new drug approved, their SG&A, their selling, general, and administrative expenses goes through the roof.
It usually does, yes.
They have to hire an army of 500 sales reps, lease a fleet of company cars, buy lunches for doctors across the country just to market the drug.
And that is the genius of MediWound's corporate structure. They utilize an asset-light commercial partnership model. They do not hire armies of sales reps.
Oh, okay.
They rely on exclusive regional distribution partnerships. Vericel handles the massive SG&A expense of marketing to the U.S. burn market. Kanken Pharmaceutical handles the marketing in Japan.
And what about EscharEx? Who handles that?
For EscharEx, they have already established a clinical collaboration consortium with major global wound care powerhouses like Mölnlycke, Solventum, and Memedex.
So the partner takes on all the massive marketing and sales overhead, and MediWound just sits back and collects a high-margin transfer price and a royalty on every vial sold.
Precisely. By keeping their operating expenses totally decoupled from the commercial scaling of the drugs, management projects that product gross margins will rebound from that painful 10% up to approximately 65%, once the new facility is fully utilized.
So that's how they get to profitability.
Exactly. This asset-light structure is exactly why they project achieving positive operating cash flow in 2028.
So we have all the pieces on the table: the biology, the military contracts, the phase 3 trials, and the accounting. What does this all mean for you as an observer of the biotech landscape? Let's synthesize the bull case and the execution risks.
It's important to weigh both, definitely.
I want to introduce an analogy to summarize where MediWound sits today. A lot of analysts call them a coiled spring, but I hate that phrase. It's too cliche.
It is a bit tired.
I look at MediWound right now as a massive hydroelectric dam holding back a colossal reservoir of water.
I like this. Walk me through the mechanics of the analogy.
Okay, the reservoir of water represents their fundamental value. The phase 2 data proving they can beat a 60-year-old monopoly, the $140 million in sovereign defense backing, Vericel's record hospital orders, and the fully constructed factory in Israel. The water level is incredibly high, and the kinetic energy is massive.
But right now, the spillway is choked.
Exactly. The stock price is depressed because of the debris blocking the water. The EMA wanted operational paperwork tweaks. The phase 3 trial needed a few extra months to find the perfect patients. The legacy factory can't produce vials fast enough to meet current demand.
So the market is looking at the trickle of water coming out of the choked spillway and valuing the company based on that trickle, completely ignoring the massive reservoir building up behind the concrete.
Exactly. The pressure is artificial, but the energy is real. To have an enterprise value of under $200 million for a company with an approved biologic, massive government validation, and a phase 3 asset targeting a $4 billion monopoly, it represents a highly asymmetric opportunity. Once the EMA clears the paperwork and the trial data hits, the spillway opens and the value flows.
However, a dam can still fail structurally before the spillway opens.
Fair point.
We have to impartially assess the 4 primary execution risks that form the bear case. Because this is still clinical stage biotech, and the risks are real.
Let's lay them out clearly. Risk number 1, the second half revenue ramp.
We discussed that steep $20 million second half revenue bridge. It is extremely dependent on administrative government contract milestones.
Right.
If the Department of Defense or BARDA gets bogged down in bureaucratic red tape and delays a milestone sign-off by even a few weeks, pushing it into January 2027, MediWound will drastically miss their 2026 financial guidance.
And Wall Street will punish that miss, regardless of whether the money was guaranteed to arrive eventually.
Absolutely.
Risk number 2, the clinical binary risk.
The phase 3 ValueE trial top-line data reading out in mid-2027. No matter how incredible the phase 2 data was, phase 3 trials in chronic wounds are notoriously tricky because elderly patients with comorbidities are unpredictable.
So if it fails?
If EscharEx fails to hit its primary endpoints with statistical significance, that $1 billion peak sales thesis evaporates overnight and the valuation collapses.
Wow, okay. Risk number 3, regulatory timing.
The final EMA approval expected in late 2027, followed by the inevitable FDA facility inspection. If inspectors arrive and find new issues with the expanded Yavne facility, perhaps disagreeing with how the workflows were implemented, the revenue bottleneck will persist well into 2028.
And finally, risk number 4, geopolitics.
We cannot ignore the ongoing Middle East geopolitical situation. MediWound's corporate headquarters, their primary research staff, and their sole manufacturing footprint are all located in Israel,
which introduces significant risk.
Any escalation in regional conflict introduces severe supply chain disruptions, logistics delays, and operational risks that are completely outside of the CEO's control.
It's a high-stakes landscape, balancing massive scientific and government validation against the harsh realities of global clinical execution.
Which brings us to the end of our deep dive.
It's been a fascinating journey through the data.
It really has. But before we go, I want to leave you with a final provocative thought. A puzzle piece to mull over on your own that wasn't explicitly spelled out in the recent earnings calls, but is quietly reshaping this entire sector of healthcare.
It has to do with the broader wound care ecosystem, specifically regarding advanced skin substitutes, often called cellular and tissue-based products, or CTPs.
These are incredibly complex, incredibly expensive biological grafts used by surgeons to close severe, gaping chronic wounds.
Right now, under proposed Medicare and Medicaid CMS reimbursement rules, there is a massive regulatory shift happening. CMS is proposing that these highly lucrative skin substitutes will only be financially reimbursed to the hospital if the treating physician can definitively document that the wound bed was adequately debrided first.
You cannot just slap an expensive, high-tech skin graft over dead necrotic tissue and expect the U.S. government to pay for it.
No, the wound bed must be fundamentally clean, and healthy granulation tissue must be visibly present before the graft is applied.
Now connect the dots. If EscharEx successfully navigates its Phase 3 trial and becomes the undisputed, clinically proven fastest way to achieve a clean wound bed doing in 2 weeks, what takes SANTYL 8 weeks? What happens to the market dynamics?
It fundamentally changes MediWound's position on the chessboard. Does MediWound evolve from being just a drug developer into an absolute prerequisite bottleneck for the entire multi-billion-dollar skin substitute industry?
If you manufacture a high-margin skin graft, your product's commercial success and its ability to get reimbursed suddenly depend on EscharEx being used first.
Exactly. And if that becomes the new reality, how long before a massive skin substitute player simply tries to acquire MediWound outright?
If you control the necessary first step of the procedure, you control the gateway to the entire multi-billion-dollar treatment pathway. It's an incredibly compelling strategic question for the next 24 months.
It certainly is, and it all traces back to that emergency room, replacing the trauma of a surgical blade with the targeted precision of a plant-derived enzyme. Thank you for joining us on this deep dive. As always, keep digging, keep connecting the dots, and keep questioning the consensus.